in primary care may have. So, it's the key. What we're going to do is go through what our comprehensive exam looks like. So you can pick up parts of that you can use in your exam, or maybe there are parts you'll do throughout your kind of multiple visits with the patient over a number of weeks. And the key also is to build rapport. And as we're doing the exam, you're trying to educate the patient too. And I think it was mentioned earlier, patients have, they'll get their X-ray report or their MRI report. They've got a lot of kind of misinformation about what's going on in their body. And so you can use the exam, I think, to try to lay the foundation to make a correction of some of those maybe wrong or inaccurate assumptions they have about their body, as well as when you're trying to figure out what you're going to recommend from a treatment standpoint. So the overview of the exam, I mean, it's definitely comprehensive. You want to look at pain behavior. Pain behavior is how they communicate to the environment that they're in pain. So think about a patient, especially a patient with chronic pain that's maybe grimacing, guarding. They look like they're not in any distress. And then when you start to examine them, they may be flailing their arms. It's not that they're consciously doing this, but many times it's related to distress and everything else. So that's more of a global thing to look at. We look at their gait, their motor strength, their muscle stretch reflexes. We're going to try to give you some tips on how to do better dural tension testing. Many of you are familiar with straight leg raising. There's other ways you can kind of tweak the nervous system to kind of pick up on radicular types of pain. We'll also touch upon sacroiliac joint testing. Wilson mentioned the sensitivity may be high, but the specificity is low. But still, multiple positive tests may help you to kind of better understand that this is coming from the SI joint versus maybe their lumbar spine. We think in our clinic, we see a lot of myofascial pain. I think even in primary care with acute pain patients, there's always some type of, or many times, a myofascial component. So we're going to touch upon some of the referral patterns as well. So just to kind of, again, lay the foundation a little bit, if you look here at these two diagrams, a lateral view and an AP view, left and right, there's a lot of different structures that can be pain generators. There's the disc, which many patients are always thinking about, but there's so many more. You have the posterior longitudinal ligament. You have the inner spinous ligaments, the ligamentum flavum. Looking at the AP, you have the iliolumbar ligament, the SI joint. So a lot of different soft tissue there that can be causing pain. And it's also important to remember that there's, different tissues provide different types of stability. Muscles provide stability. We'll touch upon that. We also have ligaments that can provide stability. Some ligaments can also give proprioceptive feedback. And then we have the bony articular structures in the disc. So, very complex structures in the spine. And we're going to be using the physical exam to help kind of tweak where we think the underlying, cause of pain or one or two of those different types of contributing to their pain are there. Wilson, any comments on the spine segments and tissue?
One of the things that it's not very common but overlooked is interspinous ligament strains. So the ligaments that sort of connect the spinous processes, especially in younger patients who are engaged in like contact sports, could have a potentially a tear, but definitely a strain. And they kind of have midline neck pain or back pain from those hyperflexion injuries. And so, just keep in mind that there are other pathologies, as we call it, in posterior column injuries. Yeah.
And this is actually just to start us thinking about the muscles. And again, I think we spend more time on our exam picking up on these myofascial changes. If you look to the right there, this is the iliolumbar ligament, which attaches from the ribs to the ilium. Most patients, it's normally provides rotation and some stability, but with injury or loss of motion in the lumbar spine, we see patients with very tight quadratus lumborum muscle. And the quadratus lumborum can also have trigger points where you can get radiating pain. So we have, not just the lumbar paraspinals, but quadratus lumborum. We'll talk a lot about psoas and some of the other muscles and these patterns we see with inhibited muscles that are also going to be causing pain or can be foundations for myofascial trigger points. This is another diagram, just more looking at the facets. Remember the facet joints, there's a superior and articular facets. These are diarthrodal joints. So they have a superior, inferior articular processes, and they also have a capsule, just like your hip, your knee, and other joints in the body. And they can kind of develop, synovitis. They can develop stiffness, capsular laxity, arthritis, and then instability. So I think Wilson mentioned even people kind of cracking their back. That may be just some redundant tissue in their facet joints clicking with rotation. So again, the facet joints are going to change. If you think about the spine, say 80–90% of the forces are going to go through the disc. As the disc wears out, more and more percentage of forces goes through the facet joints. So what we start to see over time is facet enlargement. And I'm sorry, I'm having trouble with my pointer here. But if you look to the right, as the facets enlarge, that's also going to impinge on the foramen where the nerve roots are. And so again, the facet joints, hard to test, but can also be a pain generator. And especially with spinal stenosis, as we talk about those multi-level changes, you're going to see changes on exam with loss of motion and restriction. And sometimes just getting the patients to move a little bit more, get a little more motion in their facet joints, that actually can help pain, separate from the interventional procedures that Wilson talked about earlier. And this just shows a lateral view with the degenerative cascade where the disc is narrowing. As the disc wears out, the foramen, that window starts to close. And to the right, you can see in the foramen, the ligamentum flavum. The ligamentum flavum will start to buckle almost like a drape on a window. And that also is going to impinge on the nerve root. And so I kind of liken it to my patients that the car's in the garage, the roof is coming down and the sidewalls are coming in. And then if you throw in the vascular changes that happen as we get older, and their veins aren't as efficient, we can get significant blood that gets stuck there, and hence kind of neurogenic claudication with these patients with multiple levels of spinal stenosis. So again, this just helps us understand those changes over time. The one thing Wilson and I wanted to make sure you got out of this was to really start understanding what are the referral patterns. We always think about a nerve root, like, oh, it's an L5-S1 disc causing S1 radiating pain. But there's so much more in low back pain than just dermatomal spread. So I like to think of it as if your tissues share autonomic development, so if they share somatomes embryologically, they share referral patterns. And this is based on afferent and sympathetic wiring of your body. So I think we're familiar with dermatomes, which is the first one, which is based on cutaneous structures. The second referral is myotomes, so like myofascial pain, where there's muscles that are triggering pain, which we'll show you. The third, which I think is missed, and we mentioned a little bit earlier, is sclerotomal. So remember, bones, ligaments, joints all have referral patterns. If you think of bad shoulder arthritis, it can radiate into the elbow. The hip can radiate down the leg. And the same thing with, the SI joint, the facet joints. And so when patients are talking to you, you're trying to get that history, kind of be thinking dermatomal, myotomal, sclerotomal. And then our physical exam kind of focuses on those three areas. And I know Wilson can agree, most of our patients may have 2 out of 3 of these, or all 3 at different levels. And then one thing just to mention, we wanted to highlight the importance of the core muscles. Core muscles are not just your abdominals. The abdominals are in the front. The paraspinals are, and the glutes are in the back. We see significant patients with weakness in those muscles. But also what's important is the roof in the bottom of that box. The roof being the diaphragm. So patients with chronic pain primarily breathe very shallow and slow, or fast, I'm sorry. And then the pelvic floor, those muscles in the deep pelvic muscles can get weak and inhibited, and also can cause loss of stability. And so a good therapy program is going to focus on all 4 components of the core and trying to figure out where the imbalance is. When many times we see patients with, say, tight hips, but then they have weak glutes. And so there's always this kind of antagonist and agonist muscles that are out of whack. And again, your physical exam may pick up on those. We just wanted to touch briefly and then keep moving here about the different types of muscles. There's short muscles and long muscles. The short muscles are like the transverse abdominis, the multifidi. To the right, we have a diagram of the multifidi. Multifidi help with kind of their one level. They help with stability of the spine. If you think of spinal surgery, they pretty much cut through the multifidi. The multifidi are also very important in proprioception. Many patients with chronic pain have atrophied multifidi. If Wilson does an EMG on a patient, he's actually sticking his needle into the multifidi to see if that segment is their nerve compression. So the multifidi are short, one level segmented muscles, but also very important because they can fatigue pretty quickly. The larger muscles or longer muscles or more global muscles are like the erector spinae, the rectus abdominis. These are usually deceleration, acceleration. They can cause increased torque and motion, but also can get inhibited as well. So the key is not all muscles are the same. You've got large muscles, shorter muscles, and then you're going to be trying to be looking at those imbalances. Many times a good physical therapist hopefully will help you with this as well. Wilson, any other comments on just these short muscles and long muscles?
No. I think when a patient undergoes PT, physical therapists do an excellent job of sort of isolating these two muscle groups, and they're very helpful. Yeah.
Okay. And so for our exam, and just from a more practical standpoint, when I do the exam and I'm doing a comprehensive assessment, and you can, I still think, apply this in your own practice. Most of the exam rooms, the table's to the side of the wall. If you're right-handed, you're kind of flipping back and forth around the patient. I like to pull the one side of the table out, and then I kind of move around the patient. And so I have my exam kind of in a pattern where they stand, they're seated, they're on their left side, then their stomach, then their right side, and I can kind of move around the patient. And it just is a lot more efficient, and you can kind of, I think, get through your exam in a more efficient manner. There's my rotisserie chicken. But again, it's just to try to keep things as smooth as possible. And then you're not going to forget parts of your exam if you're just kind of haphazardly doing all sorts of different tests. It gives you a little structure to what you want to do. I mentioned pain behaviors. Pain behaviors are really based on operant conditioning. So if you get, reinforced because you're screaming out in pain or guarding, then that positive reinforcement may play into that. So we have patients that are grimacing, groaning, overreacting. I just like to comment on that in my notes. A lot of times part of a pain rehab program or physical therapy or psychological counseling is going to really help with that. So it's important to kind of comment on pain behaviors. For the exam though, and again, if Wilson and I were together, we'd be on stage and he'd be in shorts and I'd be examining him. But for today, we really can't do that. But we're hoping you can kind of do this to yourself. For the start of the lumbar spine, I like to have the patient stand. If you can put your hands up and put your hands over your iliac crest is around the L4-5 level. Your thumbs will then come down right around the PSIS, and Wilson mentioned this earlier. The PSIS is that bony prominence, the posterior superior iliac spine. It's right adjacent to the sacrum. And so this way we're kind of getting an idea of where we are on the body, instead of just going in there and start patting on their buttocks or their lumbar spine. It gives you an idea of kind of a roadmap of where you're going. So if you put your hands over the iliac crest, your thumbs come down to around PSIS. And then if you point down to the top of their buttock as probably the lower part of the sacrum. And then I can kind of feel along the right SI joint border with my right hand, and then along the left SI joint border between that PSIS and the lower part of the sacrum. And then from that, I palpate along the gluteus muscles, and we'll demonstrate that. So the key is having kind of a plan with the tissues you're going to look at once you start the physical exam, and then you can start your process. So we'll show you this in a couple of videos. And then deeper in the glutes is the piriformis muscle. There's definitely the gluteus medius, maximus, and then below that is piriformis. All of those muscles can be inhibited. Many times we'll get kind of tightness in the piriformis or trigger points in the piriformis muscle. It's important to remember that the piriformis attaches from around the sacrum to the greater troch area. But again, we wanted to highlight some of the patterns of muscles that sometimes are going to be more painful or more inhibited on your exam. And so I'm going to show this video. This is one of our former fellows. So I'm standing behind them. We have our patients in a gown. I'm pointing to the lumbar, thoracic, and cervical spine, cervical thoracic area. I put my hands on their shoulders to kind of get an idea of, are their shoulders symmetric? I use 3 or 4 fingers to palpate through the paraspinal muscles, get a sense of any tenderness. I then again put my hands over the iliac crest. My thumbs again will come down around the PSIS. I'm pointing to the lower part of the sacrum. And then with my 3 fingers or 4 fingers, I'm palpating. You don't want to use your thumb. You get more real estate with all 4 of your fingers. And I'm palpating along the SI joint border. I then palpate along the lumbar paraspinals, right off the side of the midline of the spine. You may have hypertrophy on one side. You may have tightness on the other. Here we're pulling down his shorts, and you can see the dimple of his buttock. I put a little skin under that, and I'm probably pretty much right on the PSIS right there. And then I have the patient flex just to try to see if there's good lumbosacral motion. Osteopathic physicians and chiropractors may do a lot more complex exam, but I'm just trying to look for just good lumbosacral flexion. And then I have an example here where the patient flexes. We see this a lot. They're not really flexing in their lumbar spine. They're flexing at their hips. So very tight lumbosacral motion. here's a patient now, he's got a lot of pain behavior. He's kind of flailing his arms. We may say, you know, the pain, I palpated lumbar spine and it shot down the leg. Here we go. And that may be, you know, conscious or beyond their subconscious control. Okay, here's after a great therapy program in psychology, great lumbar flexion. Okay, so again, this is just giving us a quick kind of lumbar screening assessment. Here we're having the patient extend. I place my hands by the lumbosacral junction. He extends back. He's got good thoracolumbar extension. That may jam their facet joints. I extend him and turn him to the left. Some people think if you get unilateral pain, that may be consistent with facet pain on that side. I turn him to the right. I may be jamming his right lower facet joints. Okay, so again, this is kind of the basic quick lumbar screening motion exam. And again, I'm pressing there and across.
Just a quick comment on that.
Yep.
So like, you know, when you're beginning to palpate or just kind of throughout the exam, you know, kind of ask myself, what am I looking for? You know, obviously you're going to feel and palpate for some muscle density and some tissue. And obviously, you know, depending on the patient and how they're perceiving the pain, they could actually have an exaggerated response as the patient did right now. You know, so actually just by kind of literally poking the patient, it generates a lot of information about how the patient is receiving the pain, what their pain experience is, you know, what area of the pain is painful for them, and then what area of landmarks are you testing for. So, you know, just kind of palpating around and just kind of almost literally just kind of creating a map for yourself using your hands is actually kind of a very phenomenal way to sort of figure out, you know, how bad the pain is and whatnot. You know.
Yep. And so from that too, as we kind of move through this, like Mike Wilson was saying, you know, trying to identify different structures. So again, this was stated a little bit earlier in the day, but with facet arthropathy, you know, the facet is a zygapophyseal joint. Again, it's diarthrodal, like I mentioned. There's poor correlation with the history in the exam, but that doesn't mean you can't do some of these maneuvers or look for restriction in motion and trying to recreate their mostly lumbar pain. Again, we said it's sometimes common with extension and rotation, but again, it is sclerotomal. Remember, we said there's myotomal, dermatomal, and sclerotomal. This is a joint, and we'll talk about those referral patterns. Slipman did this work a number of years ago, and others have done the same, where they injected kind of toxic chemicals or into facet joints, and then they mapped out where these referral patterns were. And interestingly, a number of these referred into the buttock, but also into the posterior hamstring, and a small percentage of people into the calf. And so if you're a patient, you may be telling Dr. Chang in clinic, oh, the pain shoots down my leg. But really, it could be coming from a facet-mediated or sclerotomal pattern, different from maybe a trigger point radiating pain or nerve compression. So again, this is just some of the mapping of these facet joints, even though most times facet joint pain is going to refer more to the lumbar area. So we wanted to touch a little bit on myofascial pain. So these are some of the classic diagrams from Travell and Simmons that describe these in the 60s and 70s. And here you have on the right a trigger point in the psoas area, as well as in the deep in the groin, radiating to the front of the thigh. And so you have the iliopsoas muscle. All these muscles, in a sense, different muscles have specific referral patterns. There's a number of different apps you can use that map out where these different referral patterns are. But we commonly see this in psoas radiating to the leg or the groin. This is common. We see in the gluteus muscles, palpation in the buttock is going to radiate pain down into the leg. So if I say myofascial trigger point, I usually follow it with where the radiation is. So they may have muscle tenderness. That's not myofascial. If it's a trigger point, that's a myofascial trigger point, and I usually describe where it radiates. So palpation in the glute with pain into the right buttock and hamstring. Wilson, any other areas you commonly see with lumbar spine trigger points?
Paraspinals is obviously a very common area, but it's very hard to diagnose. But yeah, I definitely see it a lot in the glutes and lateral hip area. Absolutely.
And I think in the neck, you know, we're not talking about cervical spine today, but cervical paraspinals radiating to the head. We see a lot of cervicogenic headache that's really myofascial or weak thoracic or scapular muscles causing pain shooting into the head.
The upper trap area right here. Yeah.
Yep. And this is a diagram of a trigger point. So these are hyperirritable areas. They're usually weaker. The muscles get hypertrophy. There's a thought that there's kind of facilitation of this muscle segment. You can inject those. You can strengthen the muscle kind of to reset that ascending efferent and afferent loop. But many patients can have trigger points again in these kind of more regional areas. When patients come to clinic and they're complaining of this radiating pain, or you pick it up on an exam, that's an active trigger point. Many of us have latent trigger points where if I just palpated into someone's scapular muscles, you may be able to elicit a paresthesia into their hand. Remember a paresthesia being an abnormal sensation versus a dysesthesia, which is a painful sensation. But most of our patients are presenting with active trigger points, even though many of us without a pain problem can have latent trigger points. It's important with muscle pain. Muscle pain is, organ pain. So it's got a lot more overlap with the central nervous system. And I don't know about Wilson, but I've had more patients pass out with me doing a trigger point injection than an epidural. You get a hyperirritable area, a trigger point. It's a lot more closely aligned with their central nervous system. So they may be more anxious. They may get diaphoretic. And so again, it's because it's really got this kind of shared quality with organ pain. The muscles, remember, are less densely innervated by muscle fibers. And so there's more of a wider, a larger referral pattern. And then they're inhibited more strongly by descending inhibition. So remember, our brain's trying to increase descending inhibition or block pain signals. If you have more anxiety or more depression, that may actually make your myofascial pain worse. And we see patients with deep relaxation and other techniques, they're able to get their muscle pain down. So again, muscle pain, very different if we think of more nociceptive pain like joint pain or even radicular pain, which is more obviously neuropathic pain. And so the symptoms, there can be local and referred pain, like we said. The muscles may be stiff, there may be limited range of motion. A lot of this could be due to posture. We see these kind of group patterns where there's maybe muscle weakness in the glutes. And then we try to have the patient extend their leg and then their hamstring cramps. And that's just showing kind of this muscle imbalance. Again, they can elicit paresthesias and numbness. There's the local findings on exam with tenderness. You can sometimes palpate these thin little nodules under your fingertips. There's taut bands. That's named after one of the early researchers taught in Illinois. But taut bands are kind of like guitar fibers. You can like rub across it and you can feel it kind of twinge under your fingers. Sometimes just putting a needle into a trigger point, you can see a local twitch response where the muscle fibers kind of twitch right under your hand. So again, if there's anything you got out of this lecture, we hope that you'll do a little more of a myofascial assessment because I think that's where you're going to see a lot of kind of findings with patients, even acutely or chronically in clinic. Wilson, anything else with how you examine trigger points?
No, I think that's good.
Okay. So we want to get back to Wilson and I thought it would be good to go over a kind of a review of the neurologic exam. So we're going to start talking about strength testing, muscle stretch reflex testing. So for motor strength testing, most of us are 5 out of 5 strength. If you have to resist the person and you can break them, they're 4+. It's rarely that we're going to see anyone that has less than 3 strength. Now, if you're seeing a stroke patient or something with other neurologic impairments, they may be a lot weaker, but do a good job of really assessing these differences between a full, motor strength with maximum resistance, which is 5 out of 5, and understanding those patients that are 4+, that you can break them, or 4-, which is a little weaker. 3+ is gravity's removed. So again, you mostly see 4+ and 5s. And I like to also include sometimes, because patients have pain, I'm not sure if it's a full effort, if it's pain inhibited, or it could be inconsistent. You test them seated, but then you test them standing, and the strength is different. I just record what I see. So I kind of use those terms: pain inhibited, sometimes limited by effort, or inconsistent. So another thing we wanted to go over is the importance of understanding nerve roots. If we're talking about the more common places where you have a disc herniation, pretty much it's L4-5, L5-S1. But when you're testing someone, we're trying to figure out what nerve root level is the most affected, primarily when we're doing the radicular screen. So the muscles themselves aren't as important. What you want to be thinking of the group of muscles and what muscle root or nerve root are they responsible for. So if you're sitting in your chair here, hopefully, if you flex your hip, that's L2-3. If you extend your knee, that's L3-4. If you flex the knee, that's L5-S1. Ankle dorsiflexion is L4-5. And then great toe extension, which is actually a pretty small muscle. If you think of the muscle bulk in your extensor hallucis, that's primarily L5. And then if we all stood up and then did 3 heel raises, we'd be using our body weight in pressing our plantar flexion, and that's primarily S1, S2, primarily S1. If the patient's on their stomach and they extend their hip, that's primarily L5, S1. And so while you're doing the testing, it's more important to be thinking of these nerve roots, because that's where you're going to be cluing in which level are we talking about. And then also doing the muscle stretch reflexes, which may also be consistent with where their muscle weakness is. So again, hip flexion is L2-3, knee extension L3-4, knee flexion L5-S1, ankle dorsiflexion L4-5, great toe extension L5, and then plantar flexion S1-S2, and hip extension L5-S1. So again, while you're doing these multiple tests, you're thinking about this, and then you're getting your differential diagnosis kind of simplified.
Just a quick comment on that, Stephen, if you want to go back to that slide. So,
Yep.
Some people who suffered a stroke or a spinal cord injury, or for whatever reason, they had, a foot drop. And so if you actually think about it, if you have a foot drop, that's basically an ankle dorsiflexing activity. So, kind of a practical way to think about it is, oh, that person has a foot drop and they need a brace, or, they have any walking issues. But an academic way to think about it is, oh, they might have an L4 and L5, neural impingement or some sort of radiculopathy.
Or like at the knee, like a distal peripheral neuropathy, compressive neuropathy, right?
Exactly.
So your reflexes would help you with that as well, right? Yeah. And so, again, we wanted to go over muscle stretch reflexes. The other thing to remember, tendons don't have reflexes. So these are not deep tendon reflexes. These are muscle stretch reflexes. And it's important not for just semantics, but it's a muscle stretch reflexes. So it's the afferent and the efferent loop. If there is nerve compression at that link, you're going to see a reduction if it's in their muscle stretch reflex. Remember, you have lower motor neuron and upper motor neuron. We're talking about lower motor neuron lesions. And so this is a muscle stretch reflex. So we wanted to go through how to test for those. Many of us are familiar with, in the lower limb, the patella. The patella is primarily L4. So the word patella doesn't help us that much, but thinking about this as an L4 primary reflex may be better. Most people know L4, and which one do they also do, Wilson? Which one do people mostly talk about?
The
reflex.
Achilles.
S1. Yeah.
Yep.
Yeah, the Achilles, right? So Achilles is S1. So what's between L4 and S1? L5. Now, L5, we rarely see it tested. We wanted to show you that today. So patella is L4. Medial hamstring is L5. So if you get your fingers, get your left hand and flex your fingers. Come on, Wilson, you got to do this. Flex your fingers. And then you, with your left hand, grab the inside of your knee, above your knee, and the medial part of your leg, and flex your knee. If you flex your knee, you'll feel the hamstrings underneath your fingers, and then you get your reflex hammer and you hit your fingers, and you'll be able to pick up L5. It's actually sometimes easier than patella. So that's L5. And then, like we all know, Achilles is S1. So I want to show you how to do that. Again, if there's anything that's sensitive on your exam, is your muscle stretch reflex. Remember, a reflex is usually decreased if you have compression of the nerve. And say it's 20% one day, and you do a reflex and it's a little diminished, and then it gets 40% compressed. You're probably going to see a drop in the reflex. And so if there's anything that can change from exam to exam, it may be reflexes with a subtle change in their underlying spine pathology. So we have the video here of how to do the muscle stretch reflex. And here it is. So I'm seated in front of the patient, not standing. You want to be comfortable with the patient. Get this started here, sorry. And so I'm seated, they're obviously seated. I put my knee against, oh, here it is, I'm sorry. We'll point to the patella tendon. So between the patella and the tibial tubercle, medially is the hamstring, and then down low is S1. So I put my hand on the quad and my knee against their tibia so I can feel it and see it. And I go side to side because you want to look for symmetry. And then I do L5 with my grabbing the inside of their hamstrings. And then I put their foot at neutral for Achilles, or S1. So again, you're seated. You can actually, if you're more comfortable, you'll pick up differences. Again, I put my hand against their, see here, I'm sorry, I'll speed it up here. So I put my hand on their quad, I strike their patella on each side, so that's L4. I then cup the hamstring, which is L5. And again, I'm using a large hammer, not those little tomahawks. And then I put their Achilles there for S1. And the key with the reflexes, which go backwards here, is a normal reflex is 2+. If you have to distract the patient, then it's 1+. And so for me, if I can't get the reflex and it's 0, which is a no response, I have the patients, cup their hands, close their eyes and bite, and that'll distract them. And then you can hopefully pick up on the reflex. If I get the reflex, then it's 1+. So a normal reflex is 2+. If it's a little diminished versus the other side, it's 2-. I think it's important to pick up, if you're doing a lot of reflexes, you'll start picking up patients that rarely may present, but may present with brisk reflexes. So we have patients with 3+ or even clonus, and that'll tell you that there's maybe something in the upper motor neuron disease like MS or spinal cord lesion. We had a patient in our pain program earlier in the year who had a C6 radiculopathy with C6 symptoms in his left hand, but his reflexes were relatively brisk throughout his body. And as we imaged him more, he's got actually MS plaques in his brain and his cervical spine. And so you really want to do a good job on reflexes, because once in a while you're going to pick up on patients, with upper motor neuron signs.
And it's kind of important to pick up symmetry. So the cool thing about musculoskeletal exams, especially the reflex exam, is unless they have an amputation, you could always check the other side. And so if you have diminished reflexes or brisk reflexes on one side, it's always important to compare it to the other. Some people at baseline just have very symmetric brisk reflexes or very symmetric hyporeflexive. So that's not too peculiar. Maybe that's just their baseline. But if it's very different from one side to the next, then that's when you start kind of raising your some red flags. Yeah.
Yep. Okay, so for the sake of time out, so I'll skip. So we use large hammers. The tomahawks on the right here are really for pediatrics. And so you really want to be using a larger hammer so you can get it, or even a larger stethoscope, a heavier stethoscope, and getting a nice kind of flick, you can actually get a better reflex. So, I think it's kind of a waste of time to use the tomahawks. You really want to get a good hammer, and you can, or we call it reflex device. I don't think patients like you to use the term hammer when you're talking to them. But a reflex device, I think, have that in your room, and it's just going to make it a lot easier for you to get good reflexes. And we wanted to just show a couple things with radiculopathy. So moving towards that, there are different referral patterns. Remember we said dermatomal, myotomal, and sclerotomal. This would be more dermatomal. So on the bottom to the left, you see in the groin, that can also be L1. Top of the thigh could be L2. And then L3 could be the knee. Now, most of our radiculopathy you'll see in clinic is usually the lower lumbar, but we have a lot of patients that had a quote unquote failed knee replacement, and they have L2-3 disc herniation, with radiating pain into the knee. So you want to do a good job with your reflexes and understand those referral patterns. And then to the top here is on the right, or on the left, I'm sorry, is the L5 dermatome. In the middle is L4, and then sometimes S1 goes into the foot, which we'll touch upon. This is actually a good breakdown of the different nerve roots, L4, L5, and S1 across the top. There's different pain referrers for L4, L5, and S1 versus the numbness. And Wilson's going to comment on that. The key is to think about the motor weakness for each one of those levels. So remember we said knee extension is L4, dorsiflexion is pretty much L5, as well as EHL, which is L5. And then S1 would be plantar flexion. A good screening exam, for now I'm going to have Wilson do this because I can see his picture. Wilson, I want you to kind of don't hold on to the table, but try to stand from the chair you're sitting in. And then stand up, there he goes. And so that's actually a good test, a screening test for squat to rise for L4. So he's got pretty good hip flexion there. He's able to get up without pushing off. And then heel walking would be L5, and then toe walking, S1. Wilson, do you want to comment on the difference between the pain referral pattern versus the numbness? There's a lot of variability from patient to patient.
Yeah, and like Steven said, take it with a grain of salt, but typically if you have a very, very accurate physical examination, you could delineate pain versus numbness. So typically with the spectrum of nerve injuries, numbness is generally considered as like a mild nerve injury, whereas pain could be the start of moderate nerve injury. And obviously the severity severe injury is a weakness. As we know it, the pain fibers are located more on the dorsum aspect of the spinal cord instead of the ventral. So when you have dorsum aspect pain perception, it kind of follows a certain particular pattern. So we usually call that dermatomal, or it kind of traditionally follows that neurologic pattern. Numbness, though, is a little bit more complex. It's not just a matter of pain perception, but there's also different peripheral nerves that are involved. So when you have more than one area of peripheral nerve pain map involved. The areas in which the patient reports numbness may or may not necessarily match sort of the dermatomal pattern that we see. So that's the sort of the distinction. Yeah.
Yeah, here, like for S1, the pain may be down the back of the thigh and the calf, but the numbness may be more in the lateral aspect of the foot. And again, there's a lot of variability with patients, but it just gets you to appreciate this is all based on these physiologic changes at the nerve root and the severity of that. So for us, for dural tension, again, I think a lot of us are familiar with straight leg raise. Remember, if you put tension on a nerve root, and we talked about this earlier, remember under the pedicle where the foramen is, normally there's like 3 to 4 millimeters of excursion where that nerve root can move. As you get older, that gets shorter. There's also a loss of kind of the fatty tissue that kind of help that to move around freely. But if we have a disc herniation or nerve irritation is going to cause kind of hyperexcitability of that. So there's increased sodium conduction at that nerve. And so here on the right, we're putting, with the straight leg raise, we're raising the leg and we're putting tension on the lumbosacral nerve roots. And so that's lumbosacral, not upper lumbar. Now, the good thing is most of our disc herniations are in the lumbosacral region. So this is a good test, but it's only putting tension on the lumbosacral nerve roots. Another way to do it is the slump seated test, which I think is actually easier to do in clinic. And some people think it may be a little more specific. And so we want you to try to do this. So slump seated, it has 3 different positions. The first position is you're seated, you put your chin to your chest and lean forward. As you're leaning forward and flexing forward in your spine, you're putting relative tension on the cervical and thoracic spinal cord, right? And then what you're going to do in position 2 is passively, the physician's going to raise the leg, extend the leg. As you extend it, you're introducing lumbosacral nerve tension. Okay, so that should provoke their pain if they have nerve root irritation in the lumbar spine. If you're leaning forward and your leg is up and then you look up to the ceiling, you can also feel it while you're sitting here. You're then taking away kind of upstream the cervical and thoracic tension, and that should decrease the leg symptoms. So slump seated involves position 1, chin to chest, leaning forward. Position 2, where you passively bring the leg up. And then position 3, I have the patient look up to the ceiling, sometimes slightly extend back. And then I ask them if the pain has decreased in their leg. This should have nothing to do with your back pain, but it should decrease the leg pain, or if it's concordant pain, the pain they came in with. That's a good way to kind of test dural tension. Now remember that your hamstrings, you have a lot of other tissue that are kind of distal to your lumbar nerve roots that also can put tension on the nerve. So Wilson and I, we send patients for physical therapy where they may actually work on stretching their hamstring, which will also take tension off the nerve root. And a lot of times we just think it's coming from the lumbar spine. So the slump seated, again, is really easy to do, especially if you don't want to put them on the exam table. They can do this pretty quickly. Femoral nerve stretch, we don't have time to cover, but femoral nerve stretch is actually a misnomer. It's really for the upper lumbar nerve roots. And that's if someone comes in with groin pain or anterior thigh and you're thinking it's L1 or L2. If you lay them prone and you actively extend their hip and reproduce their leg symptoms, you're putting tension on the upper lumbar nerve roots. It's rare, but you will see it with patients. Wilson, any other comments on the dural tension testing?
Yeah, so probably like maybe once a quarter, I have a patient who comes in relying on basically wheelchair dependent or a power scooter dependency. And then, they have chronic low back pain and you kind of think, well, they're wheelchair bound, no, duh, why wouldn't they not have any back pain? I would just kind of see, just kind of test it out. They haven't been tested in a long time. Just have them do a slump seated test, and you'd actually be very surprised if you actually get dural tension symptoms. Then that back pain or that shooting thigh pain could be relatively easily treated with a cortisone shot or some manual therapy.
Yep. Okay, and this is just a diagram for straight leg raise, and the other key to remember is, you're putting tension on the lumbosacral nerve root. So if your patient is supine, the first 30 to 35 degrees, you're not really putting any tension on the lumbosacral nerve roots yet. Once you get to around 30 to 70, that's probably the range that you're actually putting lumbosacral tension on the nerve root. So anything less than 30, I'm not really sure if that's true straight leg raise. And then anything more than 70, if you think about it and you're really pressing, which I think is dangerous because you'll break someone's hip maybe or dislocate them, you're actually putting tension on their obturator nerve. So they'll get buttock pain. So really you can do a good straight leg raise between 30 to 70 degrees. Anything less than 30, it's probably not a true positive. Or I would just comment, 5 degrees off table or 2 inches off table, patient screamed in pain. Who knows what it is, right? You're just recording what you see. And then also remember, we'll talk about hip as well. It could be a hip pathology as well. And so axial low back pain, Wilson did a good job showing the different diagrams. It's mostly, sitting pain is worse. Static positioning, they have to keep changing positions. To the right is some old pictures of discograms. In the old days, we used to inject, dye into the disc to see if it leaked out or if it provoked their pain with pressure. They do get relief with sideline, and Wilson showed those classic diagrams of that. Low back pain, axial low back pain is hard because it can be disc, it can be facet, it can be multifactorial. So we wanted to go over facet, a sacroiliac joint. Wilson talked about it earlier. Remember, this SI joint, like he said, is a large joint. It only holds a couple cc's of fluid, but it may move 3 to 4 degrees. It may move more, and it's really responsible for a lot of force through the body. And so, like Wilson said, the joint is really pretty ratty looking. So it's a lot of times the X-rays don't really help you, but it's richly connected to those deep muscles, so it can be controlled by muscle. There's ligaments and ligaments around posteriorly and anteriorly that also can be pain generators. And it's a complex joint, just like the other joints in the body. So we wanted to show you a couple easy tests to do that hopefully could give you a better idea. Just like facet joints, remember we said this sacroiliac joint is a joint, so that would be what? Myotomal, dermatomal, or sclerotomal. Sclerotomal, right? So in here, this is Dreyfus is here in Seattle, who's kind of one of the greats in the area of medical spine. He, a number of years ago, did a classic study where he also injected kind of toxic chemicals into SI joints, and they mapped out the referral patterns. Most of those, 94%, went into the buttock, but then a good percentage also went into the thigh, the lower leg, and a small percentage in the foot and ankle, and the groin. We see patients, especially maybe women, around pregnancy or after pregnancy or after spine surgery with SI joint pain. They may have just groin pain, and it's not their hip. It's sclerotomal from their SI joint. And then very rarely into the abdomen. And so there's different tests. Like I said, if you put your hands over the iliac crest, you're around L4-5, then your thumbs come down to that posterior superior iliac spine, like we show over to on the right bottom part. And then you kind of know at least where the border of the SI joint is on the right and the left side. And so this is one of my old colleagues. She's doing an assessment prone. My other colleague's doing Patrick's, which is Faber's, but it's trying to provoke their SI joint pain. And we'll show you that. So there's the common what's called the Fortin finger test, where patients come in and they say, I hurt right here, and they kind of point below their belt line. It's actually somewhat sensitive for SI joint pain, but I think there's more provocative tests that we're going to cover, which are pretty easy, takes a couple seconds to do. Patrick's test, Gansling's test, and I'll show you prone extension. I don't like to use the names, but I think in this case, they're easy to explain. Patrick's is really Faber's. Gansling's is where you extend their leg over the side of the bed, and we'll show you that. So here's Patrick's. Again, it's Faber's, which is flexion, abduction, external rotation. And we put their ankle over the opposite leg. And then we say, does that hurt in the buttock? Remember, patients don't know where their SI joint is, or many times their back. So I ask patients, is it above or below your belt line? People kind of know at least that. Because if you do this and they say, oh, it hurts up in my lumbar spine, that's really not a true Patrick's test. But again, I like to ask people above or below your belt line, or at the beginning of the assessment, I kind of map out to them, this is your lumbar spine, this is your buttock, because patients a lot of times, they get confused where their hip is and where their buttock back is, and that may throw you off. To the right is Gansling's, and so this figure, the person's right hip is flexed, that person is holding on to their right hip, and then we're letting the left leg extend off the exam table. When you do that, you're putting pressure theoretically through the posterior border of the SI joint. Remember, the SI joint has an anterior and a posterior joint. And so this way you're actually putting pressure through the unilateral leg that's coming off the table, and that may cause pain. Remember, the SI joint are two separate joints, but they're like bookends. Sometimes you'll test the left side and it hurts on the right, and that would just be a cross test. And then below that is probably what's more commonly done, where we palpate along the PSIS and then palpate along the SI joint border with our fingers. And we're going to show you a video here with Patrick's in a second. Wilson, any comments on this kind of SI joint testing?
No, I mean, it's essentially just maneuvering the lower limbs as relative to the trunk and the pelvis, so that
Yeah.
we essentially just load the joint in either flexion or extension positioning. That's kind of the general concept of it.
And as you can see, and we're going to talk about this later, you can also pick up hip pathology. You're right there. You can do a quick hip exam and see some other restrictions. So this is Patrick's test. I know we're running out of time here. We're going to take a break here in a couple minutes, and then we'll keep going with hip. But here on the left side, I flex his hip. I can do a quick hip exam, load his hip. I can test for internal and external rotation. And so that's external rotation, usually about 60, 70 degrees. Internal rotation should be 10 to 20. It's interesting, most people lose internal rotation first when they have hip contractures. So you'll see 0 hip internal rotation. But here we're looking for Patrick. So we bring his ankle over the opposite side. And if it hurts on the left side, that would be a positive Patrick's test. Okay. And again, you can do the kind of quick hip exam. We get fooled a lot, especially with the spinal stenosis patients. They've got neurogenic claudication, they've got hip flexion contracture. And so you can pick up a lot on this exam, not just Patrick's, but it gives you time to do a hip exam. Prone extension is a good way to test for hip extension. Remember, hip extension is L5, S1. But in this case, we're going to be doing it for SI joint. So I also, it gives me an opportunity to check for their quad length. Here he's kind of tight. It should be almost his ankle to his butt, but he can't do that. Here I actually hold up and passively extend the hip, and I actually put my hand closer to their SI joint. If that hurts under my hand, that could be a positive test. And it's also test what? What are we doing right there, Wilson? We're testing for hip what? What motor strength?
Extension. Yep.
Hip extension. And all day I see people with relatively weak hip extensors, or their hamstring will cramp when they do that because their glutes aren't strong enough, and then their hamstring overfires. And that may be the only weakness I pick up on their exam, because most of us have strong hip flexors, our knee extensors and flexors are strong. So again, do a better job with these proximal muscles, and hip extension, again, as we commonly see relative weakness. And I see patients that are just weak on one side. You may have a right S1 radic, and they have weak hip extension on the right, but the left, they're 5 out of 5. So we wanted to just cover spinal stenosis for a couple seconds, and then we're going to take a 5-minute break, because we know we want you guys to pace, right? That's how we teach people in the pain program, Wilson. We got to pace. So we're trying to pace you through this lecture. So this is spinal stenosis. And again, Wilson showed this earlier. You have multiple levels of narrowing. And I think Dr. Wilcox explained it earlier. Most of our patients now have access to the MRI report before you do. And they're going to see in the report, especially an older patient, multiple levels, L1, L2, L3, facet hypertrophy, disc degeneration, lateral stenosis, just multiple paragraph after paragraph of findings. And what happens when you get narrowing across the lumbar spine is you get narrowing centrally, and you get narrowing in the foramen. And then what happens with spinal stenosis is that as we get older, our blood vessels, the valves in the blood vessels actually break down in our veins. And so as we're walking normally, there's blood, there's blood flow around all of our nerve roots. Those vessels, the blood kind of gets stuck. And because the space is so narrow, as they walk, the blood kind of gets stuck in there, and they get transient compression of their nerve roots. So as they're walking, they get kind of heaviness in their legs, and they may get radiating pain. Very different from like an acute radiculopathy with a big disc herniation. And so most of those patients want to be relatively flex forward. And so that's why we have a picture here of the grocery cart sign. So we ask patients, if you're in the grocery store and you lean over a grocery cart, oh yeah, I can walk forever. But when they're flex forward, that's opening up those blood flow, and they can walk a little easier. That being said, you can provoke their pain by having them extend. So I have them standing, and I have them extend back. Most patients can't even get to neutral, but as they're extending back, they're kind of causing, sometimes if it's severe, transient claudication, and they may start telling you they feel heaviness in their legs. You can do what's called a standing extension test. But we wanted to show you this here because we think there's probably a lot of this in primary care, and that we just kind of miss it. So again, with neurogenic or neurovascular claudication, this is a diagram of the multiple nerve roots that are compressed. And then as they're walking, this blood here, the darker color, kind of gets stuck. And then that's why they have to sit or flex forward, and that gives time for the blood to rush out, and then their symptoms feel better. So the neurovascular claudication patient may walk a block, then their legs get heavy, and then they have to sit down. The blood rushes out, and then they're able to walk again. Because of that, most of our patients want to flex forward. If they're flexing forward all the time, they've got to see the world. So they have a posterior pelvic tilt. So their their pelvis tilts, and that causes contracture of their hips. So that's why our older patients have hip flexion contracture, and they're kind of stuck in flexion. So we'll show you that here. So here, again, because they're flexed forward relatively, they have to look up to the world. And so they have a posterior pelvic tilt, and that puts pressure, kind of chronic flexion of their hips. So Wilson, do you want to stand up and pretend like you're flexed forward? And, and then as he's flexed forward, he wants to look up to the world. So what does he do? He kind of has a posterior pelvic tilt, and now his hip flexors are tight all the time. He's actually engaging his hip flexors all the time, and his knees are bent. And so for my orthopedic colleagues, this is how we keep you guys in business. You'll be doing hip replacements all the time, right? And so their hips weren't made to be flexed 24 hours a day, as well as their knees. And so what happens is their hip flexors are tight, maybe their psoas muscle, their tensor fasciae lata, and then their glutes are inhibited or weak. So we see this commonly. Yeah.
I was just going to say, it's kind of a precarious position to be in front of a camera. Yeah.
That's right. I don't want to say what that looks like, but you're doing okay, Wilson. Okay. So again, those kind of chronic changes, you may see in probably 60, 70% of your older patients, they have quote unquote back pain, right? Wilson, anything else you see with your kind of spinal stenosis patients?
Just from a practical standpoint, a lot of the patients get very discouraged because it's such a complex pathology, and they feel like they have sort of hit the end, and there's really no other treatment that could be offered to them. And I would really give them a sense of encouragement, saying that there's been a lot of different modalities that really haven't been explored. So I would just kind of give them a sense of courage and optimism to better manage spinal stenosis.
Yeah, and some of those patients, separate, they may have super tight hips, just getting their hips moving or getting them more upright, they're more comfortable, separate from epidurals and things. Sometimes we can give them transient relief. A lot of times their symptoms plateau. I think they're worried that they're going to be paralyzed someday because they just think this is a chronic degenerative process that has no endpoint. And so I think that's important. You could have them do exercises on a stationary bike because that puts you in relative flexion. So spinal stenosis patients can ride an exercise bike. I wouldn't put them on a treadmill because what are you doing on a treadmill? They're in relative extension. So again, maybe those are the patients that you put into a pool program, or they're in a stationary bike flex forward. So we're going to take a 5-minute break, I think, and then come back and then spend the last 20 minutes going through hip exam and then a little bit more on physical therapy. So if we could come back at about 17 after, we'll continue there. So thanks, guys, for hanging in there. And then if you want to send questions in the chat, we're happy to look at those during the break too. We'll be back at 2:17 in about 5 minutes. Thank you. Okay, we'll get started here in about a minute. Any questions? If we can take a quick question as people get back on, if they took a break. About I know we went through a lot on the physical exam, but any questions out there? We'll try to look in the chat.
So it looks like Dr. Bishop just asked, what's a good sleeping position for someone with spinal stenosis, and would NSAIDs be helpful since it sounds like mainly blood flow is related? Stephen, you want to answer that one?
Yeah, well, I think from a positioning standpoint, thanks, Dr. Bishop. I think most patients don't really want to be even in bed in extension. Most spinal stenosis patients have like a hip flexion contracture. They can barely get on their stomach. So it might be rare that they can get on their stomach. The inflammation, unfortunately, I don't think an NSAID would work for that type of neurovascular claudication. I mean, there's definitely different studies. This is off-label use of like the gabapentinoids, and like Wilson mentioned for neuropathic pain. They actually many times will tell you that there's physiologic changes at night, that their neuropathic pain may actually be worse at night. They might get more cramping in their legs. So some of our older patients, you want to be careful with gabapentin and those meds with older patients, but we may just dose gabapentin at night for their leg symptoms. But unfortunately, the NSAIDs really won't work. It's kind of a chronic nerve root irritation, not the inflammatory type that we think of with traditional NSAIDs.
Yeah, and just to kind of echo on that. So a lot of patients with spinal stenosis, they'll tell you that they sleep on a sleeper sofa, as opposed like a lazy boy, like an armchair, as opposed to the bed. And when someone tells me that, I mean, I'm already thinking spinal stenosis as their diagnosis. So their sleeping position obviously does play a huge role. Just the natural reproduction of the Sharping cart sign would be to be in flexion position. So a lot of these patients, that's the whole reason why they like the lazy boy and the armchairs, is because it gives you about a 10 to 15 degree flexion naturally. It supports you. People who could kind of expand on that often invest in those sleep number beds that actually have individualized flexion areas or support areas in the knees, the low back, the neck, the thoracic spine. And they obviously love it because it supports them in a flexion positioning. So people who can't obviously have access to those resources, they end up kind of sleeping on either their side or kind of in a slight, I don't want to say as exaggerated as the fetal position, but they generally prefer a flexion position. Yeah.
Okay, so we're going to kind of move through and just touch a little bit more on the hip exam, because again, a lot of overlap with quote unquote low back pain and what's actually coming from the hip and vice versa. And like we said, with spinal stenosis, especially if you have degenerative changes in your lumbar spine, you more than likely have degenerative changes in your hips. And so patients can present with both. So first, we wanted to this is a diagram of the pelvis with the ligaments, and kind of understanding that it's not just the glenohumeral, the hip joint itself, but the ligaments can also be pain generators. You can get instability. Wilson, any other comments with just these other soft tissues that we kind of forget about? And we're going to go through different types of pain from the hip, but just from an anatomic standpoint.
No.
Oh, yep. Okay. And then we have hold on here. Sorry. So again, the muscles are going to be important. This is the gluteus medius to the left, and then the deeper muscles, minimus. But you also have piriformis, the other muscles that attach to the troch. I think Dr. Wilcox talked about different muscle tears and tendon tears that you can have into the hip. So a lot of important tissues in a small area. So again, I palpate the iliac crest and then into the gluteus muscles, and then between the ASIS, which is this bump in the front of your hip, in the front of your pelvis, to your greater troch is the tensor fasciolata. That's a hip flexor that many times will be tight or also have trigger points. So again, you have these ligamentous structures, muscle structures, separate from even inside the joint itself.
Mm-hmm. And a lot of the muscles that sort of attach the greater tuberosity of the pelvis, are muscles that bring your legs closer together or that extend your hips. So, or brings even sometimes even flexes your knees. So a lot of there's about 6 muscles that sort of insert into that ischial tuberosity area. And so a lot of patients who have like a partial tear or some sort of disruption into that area can complain of growing pain or kind of perineal pain, but the issue was the hip all along.
Yeah, and we're going to try to break that down so you can get a better understanding of what your kind of quick differential is when someone comes in and says, my hip hurts, right? And it can just be so many things. So and remember, we have the bursa as well that are going to be underneath those tendons getting irritated. So you can look at hip, the differential could be osteoarthritis, rheumatoid arthritis. It was mentioned earlier, femoral acetabular impingement, labral tears, maybe in younger patients, iliopsoas bursitis, piriformis syndrome. So really spanning, joint versus muscle versus ligamentous, and then not forgetting myofascial. And the SI joint can also, like we said, because it's a sclerotomal pattern, they may have SI joint pain radiating into their groin or their hip. And this looks like a really bad X-ray where you've got complete loss of the joint space. Yeah, and I imagine they have loss of motion in their hip. Remember, the hip capsular pattern is usually loss of internal rotation. And if you think about it, if you have loss of internal rotation in your hips, you get more pressure through your facet joints. So a lot of times where you're treating people's facet pain, yet their hips are probably the ones that contribute to it because they don't have any motion in their hips, relatively motion, so they have more pressure going through their back. And we see this with golfers, older golfers with facet pain. Their hips are really tight. You loosen up their hips and their facet pain gets better. Sorry to go on a tangent there, Gordon Wilson. Okay, so we broke this down here into intra-articular, extra-articular, and the hip mimickers. This is an older article, but I think it nicely reviews how to break that down. Intra-articular are like labral tears, loose bodies, femoral acetabular impingement. Extra-articular in the middle is outside of the joint, so iliopsoas tendonitis. You can have iliotibial band. You can have snapping tendon syndrome where the IT band rubbing against the greater troch. Gluteus medius or minimus tears. Stress fractures. There's different types of stress fractures. You can have fatigue fractures, insufficiency fractures. Dr. Wilcox showed a couple insufficiency fractures. With fatigue fractures, you could have a femoral fracture where there's normal bone but repeated stress. So someone's excessively training. And then there's insufficiency fractures where the bone itself is impaired, and then you're putting normal stresses through there. So someone with other metabolic issues that are kind of prone to insufficiency fractures. So that might be kind of exercise-induced hip pain, but it's related to a stress fracture. Wilson, do you want to comment on some of those kind of intra-articular causes of hip pain?
Yeah, so one of the cool things that you can do on a physical exam that separates intra-articular versus extra-articular pathology is range of motion. So when you first see the patient and have them actively flex, extend AB duct or AD duct, so any sort of movement that's patient-induced is called active range of motion. And if they're able to do it, or if they are not able to do it, excuse me, let me back up a little bit. So any sort of active range of motion, if they're able to do it, but they say there's a lot of pain, you could think a little bit more extra-articular pathologies, simply because when there is any significant intra-articular pathology, the patient usually are unable to do it because either the pain is so intense or because of that structural deformity. Now, after you test the active range of motion, you kind of take over and you could do what's called a passive range of motion exercise. And so then it kind of deactivates a lot of their muscle tissue. And if you're able to, let's say, get greater range of motion, whereas they weren't able to, then you sort of rule out any sort of significant intra-articular pathology that you are suspecting anyway. So just to recap, if they're able to do more active range of motion, achieve a higher range of motion by themselves, then that kind of points away from an intra-articular pathology. Whereas if you're able to do more than what they were able to do, that sort of rules in more intra-articular pathology.
Yeah, and I think too, like when we're going to show how we do the kind of normal screening exam of the hip, and even something like femoral acetabular impingement, they talked about different types of, is a cam deformity or a pincer deformity where the acetabulum is kind of overgrown, and then if you put pressure on that, you can induce pain. So like with femoral acetabular impingement, it's a little different because those patients, if you flex them and adduct them, that could increase pain. So different tests may kind of clue you in. Patients may not be able, if they squat, they have groin pain. That could be femoral acetabular impingement. But again, you can use your exam to help kind of straighten that out. But those are just kind of some of the areas, thinking intra-articular, extra-articular, and there are hip mimickers, which we don't have a lot of time to go through, like sports hernias. You can have peripheral nerve entrapment in the groin, which is rare, but some of those patients may also report. But we didn't want to go into that area today. The other one was going to be labral tears, which we'll touch upon, which we see it a lot. But then also it is sensitive on MRIs where you see labral tears and there's no real pain from it. So you have to be careful kind of over interpreting some of the imaging. So that's why your exam is going to be important. So these are the different types. You could, like Wilson nicely explained, you can do active and passive range of motion testing. Faber's, again, flexion, abduction, external rotation, motor strength testing. We'll go over some of the provocative testing you can do. Again, the myofascial assessment is going to be key, especially iliopsoas, which I see is missed a lot. And then bursa tenderness around the lateral aspect of the hip. And then the IT band, which is that really thick fascia that kind of combines all of the muscle tendon insertions along the side of the leg, and it attaches from, up in the hip area down to this lateral aspect of the knee, the IT band. And a tight IT band is commonly out there, and we're going to show you how to test for that. So that, again, a hip exam, you can do loading, you can do internal and external rotation. The normal capsular pattern is you lose internal rotation first. You may see on one side they have 0 internal rotation. Left side, the opposite side, they have 15 degrees of internal rotation. So that may clue you in that they have a capsular problem. And then we'll go over Ober's test and some other testing, including Thomas test as well. So with Ober's test is we're actually extending the hip past the neutral line, and then we're letting the leg drop. Normally the leg, the knee should drop below this line that goes through, and the knee should actually cross midline. A lot of patients have a tight IT band. The IT band, the tensor fasciae lata, tensor fasciae lata connects from your ASIS. If you feel like right under in the front of your abdomen, the bump by your belt line, that's your ASIS. From your ASIS, and you feel over towards where your greater trochanter is, that muscle is the tensor fasciae lata. It's a strong hip flexor and many times can get tight. Also, if this is tight, you can get tight IT band, iliotibial band, and when you bring their leg back, their leg's going to stay abducted. And you also have patients with tight hip flexors, so sometimes this test is difficult. So this is how you do the test. So let me get the video going here. So the patients on their side, I make sure they're perpendicular, their back's perpendicular to the table. I slightly flex their knee and their hip. I put my hand on their right. Here I'm putting my right hand on their pelvis to stabilize it. And then I bring the leg back and then I drop it down because you want to make sure you clear the iliotibial band. Here his knee comes down pretty nicely. It'll almost cross the midline. Okay. And it's also a good way you can test for hip abduction. Okay. So again, I grab the knee, I flex them at the knee and the hip. I stabilize the pelvis. I kind of lean over. I put my hand under their knee and I kind of bring that back. I raise it up and then back past the neutral point. And here his knee's going down. It should be a little further down to the table, but we'll call that a negative test.
Are you applying any downward force, or do you just let gravity do it?
Oh, I just let gravity do it. Now, that's a good point. So you want to see gravity because then that's where your soft tissue restriction is going to be. But then I actually put their legs straight, and that's a good test for hip abduction. And again, from this point, even doing the Ober's test, you can pick up hip flexion contraction. They're super tight in their hip, and you can't even get their knee to neutral, the neutral point. So let's see if I have an abnormal one here. Sorry. This is more than enough that you guys can get after an Ober's test. Here we go. So here, look how high his leg is. So that could be a hip flexion. It could be tensor fasciae lata tightness. It could be IT band tightness. And that's going to throw off the mechanism, some of the biomechanics of the knee as well. And here's where I test for hip abduction. Sometimes you'll see people cheat. They'll turn their leg in, internally rotate. I put them in neutral. It's a little harder. Wilson's laughing. I know. I'm a motor testing geek. Okay. Okay, so then Thomas test is actually pretty easy. So remember the psoas muscle, which I think, again, one of those muscles that is ignored many times. The psoas muscle attaches from your lumbar spine and your ribs and actually crosses the joint, your groin, attaching to your hip. And so it can get tight. If you put their hands, if they're laying supine along their ASIS, and then your hand drops more medially, you'll be right around the area where the psoas is. I then have them flex their hip, and I can feel the psoas muscle right under my fingers. And I see a lot of patients really tight on one side versus the other, or they have tenderness. Remember, there's the iliopsoas bursa that's really deep in the groin. You can get bursitis. People can do ultrasounds and inject those, but that's also kind of common. The tight hip flexor or myofascial pain in the psoas muscle, and then that referral pattern will be down into the leg. So let me just show you the video here of just if he had a tight Thomas test. So with Thomas, I have him bring the left knee to his chest, and then you can see here, because he's tight on the right side, his leg automatically goes up, and that's because his psoas or iliopsoas is contracted. Normally the knee should stay flat on the table. So again, a quick one. You can also have patients do this off the side of the table, and when they lean back, the other leg will come up past that neutral point. And again, when you have them in that position, you can also do a quick hip exam, internal, external rotation. And then here, we didn't have enough time to go through this, but we have them, I have them flex their knees, and they can do a bridge. And I check their core strength with doing a bridge. And then I have them hold one leg out, and they're doing a one-legged bridge. And many times you can pick up weakness there, or they get increased back pain or spasms in their hamstrings. Okay, so labral tears, we've got about 10 minutes here. We wanted to get through this and then a little bit on physical therapy. It's more common in females. Again, Dr. Wilcox talked about it earlier. They can present with groin and anterior hip pain. You know, anterior labral tears may be more groin pain. Posterior labral tears may be more buttock pain. The labrum, you know, stabilizes the hip joint. It acts as a seal. The tears, again, are more commonly anterior. Usually they're with some kind of trauma. Again, I see, though, that sometimes these are overcalled because, you know, they may have a tear, but we're not sure if it's actually contributing to their pain. Wilson, any other ways that you test for labral tears?
So yeah, the classic most sensitive test is the FADER, or the femoral, or the flexion, anterior adduction, and internal rotation, and that's one of the more sensitive tests for labral tears. But again, like Stephen said, you know, labral tears, when you see it on MRI, which is very sensitive to pick up, may not necessarily be the source of the pain. And I think again, Dr. Wilcox sort of shed some light on this. Just because you see it on MRI doesn't necessarily mean that is the causative agent for the pain. So 10% of labral tears, even though it's moderate, isn't symptomatic. So just take it with a grain of salt. It's very attractive to pinpoint whatever hip pain or groin pain or buttock pain to a labral tear, but the surgery often is very invasive. It's very the rehab and the recovery is very extensive. So it's a lot of reassurance and counseling is done for these issues.
And you want to make sure it's not like psoas or something else in that area, you know, mimicking that on top of the labral tear on MRI. So, yep. And what I'm seeing, it's mostly been from trauma in younger people, but, you know. And we just wanted to include this. Oh, I'm sorry. Yep.
Yeah, just quick for imaging for labral tears, straight MR or MR arthrogram?
Great question.
Good question.
Yeah, that's a great question. And you know, back in the days, just even maybe about 20 years ago, that question would be a little bit more pertinent, where, you know, there are certain pathologies or age groups where injecting the contrast would be more relevant. But nowadays, even just the 1.5 Teslas on the MRI machines are so great, like the image quality is so good. So I would say for majority of the patients who are, you know, 50 plus, you don't need really contrast to see anything, or to see everything, I'm sorry. But if you have any suspicion for any peculiar pathologies, not just a simple labral tear, like some of the occult fractures that was in the hip lecture earlier, or younger patients, you typically want to do contrast. So just to recap, so you would capture more than 80-85% of your patient population without contrast. So you know, if you have any suspicion of intra-articular hip pathology, then just order it without contrast. for any concerns of looking for zebras, then or younger patients, then you want the full picture using contrast.
Yeah, and I think too, what you're referring, the orthopedic doctors you're working with, I was practicing in the Midwest, and the institution I was in, they all wanted arthrograms. So you have to kind of know, because you don't want to obviously have a patient do a lumbar hip, and then a hip MRI, and then they wanted it with contrast. So like Wilson said, though, the imaging quality has gotten so much better with the traditional one. The advantage sometimes with arthrogram is sometimes we can ask radiology to include steroid with the injection when they do the arthrogram. And so I've had some patients with a hot hip where we weren't sure what was going on, and they were able to at least kind of add a little therapeutic benefit. But again, that's maybe an outlier, and I would defer it to the orthopedic surgeons if you're working with them. And then it's now, I think we're using a lot more diagnostic ultrasound, and the musculoskeletal ultrasound guys sometimes are doing that even before maybe limiting the number of MRIs that we're doing for hips. So,
and then I would just say, if you're not sure at all and you really don't know what to order, just order it without contrast, or order it with contrast. And in the comment section, just say, prefer without contrast if indicated. And then the MRI techs or even the radiologist would be able to sort of figure that, cues them to think, okay, this is what's more appropriate, and they'll go with the better option so that they don't bother you and you don't bother them.
Yep. Okay, and in this we wanted to show you, because I think a lot of us are hopefully doing less virtual visits, but we're still doing virtual visits, and virtual visits aren't going away. And it's been very helpful in our clinic. But this is a great, I think, review from Mayo Clinic Proceedings that really walks you through. They have different videos of the entire musculoskeletal exam and how you can do that with a virtual exam. And they give nice kind of clinical pearls on how to do that. So again, this was just more for a reference. If you're struggling with that, you can really do a good part of your exam with the patient. And I think it actually adds a lot more to your virtual visit than just looking at the patient as they're sitting in their house. So, but Wilson, I'm not sure if you're doing any of these kind of tests, but again, this is a great reference. You go online, you click it, and it'll take you to the videos, and they break it down by body part. So, Wilson, are you doing any of these with your patients on virtual visits?
Oh, absolutely. The good thing about virtual visits is the convenience, but the bad thing about virtual visits is you can't get your hands on them. So whatever that they can do, it's a good reflection of how much activity they could tolerate and exert. So if they could do a true like seated Faber or a true slump test, then that's great. But just kind of observing their general activity level and their ability to participate, I think, is a good clinical clue. Yeah.
And obviously, I don't think all of us have exam rooms like this person did, right? So, but yeah, I think it's good. Even slump seated, you could do. I have patients doing just kind of self trigger point exams on themselves, and just kind of make it a little more interactive, and you can pick up sometimes some good things. So even sensory exam, I've done with patients, through the phone, but it takes a little coaching, but it does make the patients a little more active. So we have 5 minutes. We wanted to go through some of this kind of specialty areas around physical therapy, and there's so much you can do with physical therapy. There can be kind of modalities, there can be active exercises. We want to have enough time here, so let me just kind of whip through this. Now, especially with video and links you can give patients, you can do it as a clinician. The therapists are giving patients a lot better material instead of like stick drawings of 20 exercises for people to do. But these are some typical examples of spine stretches, cat, cow, for getting their spine moving. The prayer stretch with lateral bend. Again, a lot of movement into the spine. So I like to ask patients when I send them to physical therapy, when you come back, let's review 3 of your exercises. And I document that in my note. Patient demonstrated their prayer stretch and their prone extension test or whatever. Many times we ask the patients if they went to therapy and they say yes. And I'm like, are you doing your exercises? And they're like, yeah. I'm like, oh, show them to me. And they can't even explain it, right? And they're like, okay, that doesn't make sense. But they want their pain medicine refill, right? So I actually try to explain to them, the reason why I'm sending you there is I want you to get a couple of these exercises. At your next visit, let's go over that together. And I make that part of my exam. You really want to reinforce why you're sending them physical therapy. If they come back and say, oh yeah, the person just put hot packs on me and had me ride the exercise bike, that's probably not a good PT place too. So it'll clue you into the kind of exercises they're getting. So, I ask them which exercises they're doing. We kind of quickly review that, and I document that in the chart. But again, there's different types of approaches. There's flexion-based, McKenzie, which is more called mechanical diagnosis and treatment. And last thing we wanted to touch upon, because we only have 5 minutes, was pain neuroscience education. Pain neuroscience education is really teaching patients about their nervous system and how their nervous system gets modulated with chronic pain. So especially with chronic pain, This is a big area of growth in the physical therapy world. A lot of therapists are trained to do this. We use it at our pain program in Seattle at Swedish Pain Services. It just teaches patients how to understand, how the nervous system changes, because the old thinking that this was biomedical and it was all the same doesn't really work. And so this kind of pain neuroscience education has really, I think, helped kind of link the depression, anxiety, fear of movement, and how they process pain signaling. And so we're just going to touch upon this, but just to have you aware of it. Again, we're seeing a big growth of this in the physical therapy clinics. So with McKenzie, this is from a number of years ago. The idea was in certain positions, repeated movements, the disc moves into a certain position. It can help centralize the pain. This is still being taught. A lot of therapists have specialty training in this. And so with it, they're assessed by the therapist. This will be a patient with low back pain and say pain going down the right leg. They see the therapist has them do these repeated movements, and they see if they can get the pain to centralize or go from the leg to the back. And if it does in those repeated positions, they do their exercises in those. Most of McKenzie people that respond, it's usually extension. So it's wrongly called extension-based therapy, but most patients do extension. I've got back pain 3 times a year. I've got horrible leg pain down the right side. I know I've got a disc herniation, but I respond to prone extension, and I can do repeated extensions and the pain goes away. So we'll show you this, but this is another one, again, for you to be familiar with. So here's the example. The patient here is in flexion. So the therapist has them do repeated flexion. As they keep doing it, their pain actually gets worse. So this is peripheralization. That's not good. You don't want that to happen. Now we got the guy with different underwear on and different hair. He's doing prone extension. So as he does repeated extensions, look at the leg in the middle there, the red color. The pain is going from the calf up into the back. So he's centralizing. So his exercises may all be extension based. And there's different theories on what this does to the disc itself. But this patient may be a McKenzie patient, and that's part of their exercise program. So again, McKenzie or extension-based treatment, again, it's not always extension. Sometimes people centralize with flexion. There's some patients that don't respond to this, and there's ways that the therapist will categorize them. But McKenzie or directional preference is a common spine therapy that's out there.
Assume that physical therapists in the community will be familiar with this.
Yeah, I think if you put it on your note, that's a great section. When I send patients to physical therapy and it's outside of the system, I don't know the therapist specifically, I said, please assign with spine therapist. Most therapy places have a couple of therapists that like to do spine, and those guys will probably more likely, have extra training. I may put in, I also put in my notes, no modalities, because I think that means they're going to be wasting a lot of time putting hot packs on them on a lot. I may include in my note, instruct patient in 3 or 4 exercises to review with me at the next visit. At least they are the therapist knows that you want to be more involved and get a little better action out of the therapist. But I think the easiest way is just to find out at the different places you use, who are the spine therapists, and then you can identify therapist X or therapist Y. And then that therapist knows that you take an interest in what they do, and I think they actually do a better job. So going back to your question, it's great. Find out in that therapy clinic who is their spine therapist. And I think a lot of times that they can push those referrals to the therapist they're interested in that. Wilson, any comments? That was a great question, because it's really hard, just sending a patient, say, a eval and treat, you don't know what you're getting many times. And then they don't do well, and then they blame it on the therapist, right?
Right. And then that
Wilson,
reinforces their belief that pain meds are the only way to get through this.
Right.
Exactly.
Or that the exercises make my pain worse. And like Wilson said, they maybe showed them the wrong exercises, right? Or the patient is seen by, the other thing to look out for is every day they go to the therapy place, they see a different therapist. That's not a good sign. They should be seeing the same therapist. They're, it's not the shake and bake every 15 minutes. It's the hot pack, ride the bike and walk on the treadmill. I'm not sending people to therapy to walk on a treadmill. That may be a small part of it, but the daily stuff should be instructing them on exercises. So hopefully over time you develop 2 or 3 different therapy places that you like, and they take kind of pride in it. And, the therapists do a good job. We don't have time, but we want to touch on pain neuroscience education. A lot of the therapists are going to courses and learning that, which also includes, learning about the nervous system, and they teach patients that. I'm sorry we're running out of time. These are great questions on the therapy side. So maybe next year that's what we could talk about. So pain neuroscience education is just a way they use different kind of stories. And here they're using this idea that your nervous system is sensitized. And so aerobic exercise, relaxation, meditation, diaphragmatic breathing, all of those are going to quiet down your sensitization. And so the physical therapists are actually teaching them that. And so our therapists are taught in this pain neuroscience education. It's been really good because I think it helps link the cognitive behavioral stuff, the relaxation, and that they can kind of control their bodies. Separate from, the kind of biomedical approach that, your disc is horrible and you can't move and bend. It really focuses more on how your